كارير. حضرتك لو تحب نبدأ الأول دلوقتي أبدأ يعني.
الحقيقة زي ما تبغى. أنا عندي one patient is coming يعني شديد انت ممكن أبدأ لو حبيت.
على طول دلوقتي؟
لا زي ما تبغى انت، شوف عشان ما نلخبط. انا برنامج على اساس 10 ابدا، لكن لو حبيت الان انا ما عندي مشكله.
طيب ما فيش مشكلة، نبدأ مع الدكتور أحمد الأول وبعدين
طيب
حضرتك تكون خلصت. إيه رأي حضرتك؟
بس جريت على ان شاء الله على انا جاي لها not more than 10 وهي شويه بي بي يعني واحده اميره، فانا we have to get.
طيب بسم الله الرحمن الرحيم. We'll start our day today with we are now the ninth day of the seventh ISN Educational Ambassador Program in Africa, the Kearns Project, and we have two eminent transplant speakers today. We have Professor Faisal Shaheen from Saudi Arabia. He is the co-founder and co-founder of many societies in the Middle East. He was a co-founder of the Saudi Society of Transplantation, and he will discuss with us and give us illustration about how to build a successful transplant career. And we have our eminent Professor Ahmed Halawa. He is the co-founder and director of the Arab Society of Transplantation Clinical Transplantation Fellowship Program, and he's joining us from United Kingdom. We will start with Dr. Halawa. He will discuss, we will have open discussion about an important topic. I don't think it is one of the topics that really routinely discussed in nephrology conferences, but I think it is very important that we discuss how to build very good, successful nephrology and transplant career. And it will be open discussion, so we'll need participation from all of the attendees and audience. We'll start with Professor Ahmed. تفضل دكتور أحمد.
Thank you very much, Dr. Ahmed Aqif, for this introduction. And actually, thank you very much for choosing this topic, which is very essential to know. Fine. Actually, I'm going to start my presentation or talk by asking questions. So what do you think, how do you start a transplant program? I'm going to talk about transplantation because I'm a transplant clinician. So I will open the discussion for my colleagues. So what's the essential steps you should follow to start a successful transplantation? Who can answer this question?
So please, anyone can answer, raise his hand so we can open the mic. So we have Dr. Amal. اتفضل دكتور أمل. You can unmute yourself.
First of all, we have to prepare the recipient and the
yeah, look, a wrong start. Basically, what you need is you need the knowledge. You can't learn transplantation on the job. You can't start transplant people and then you learn how to manage them. So you need the knowledge first to start a transplantation program. Transplantation is rapidly evolving. Immunosuppression is rapidly evolving. In the past, 30, 40 years ago, we used to give buckets of immunosuppression, broad immunosuppression associated with high complication rates and unbearable side effects. Do you know that when we started transplantation, we used to give total body irradiation? We used to give massive doses of immunosuppression. What ends up with? Successful kidney transplantation, but dead patient. Now, transplantations and immunosuppression are fine-tuned. We know more, but what we don't know is more than what we know. So, the knowledge. So how can you get the knowledge in transplantation? Answers, please.
Are waiting them to raise hands.
We can get the knowledge from the experts, from the previous experiences, from the centers which already manage the cases and do the transplantation, from training, from there's many routes of knowledge.
Fine. I mean, this is a generic question. How can you get the knowledge in transplantation?
So let us take also opinion of Dr. Gamal from Libya. تفضل Dr. Gamal. How you gain knowledge for transplantation?
How do you knowledge, or how do you get kidney transplant?
No, how you get the knowledge in kidney transplantation to start a transplant program, because in medicine is not allowed by all means. It's very unethical to start a job and then learn how to do it.
Sorry, I answered how do you get, but the knowledge is still waiting the answer from you.
So I can help you, Dr. Gamal, if you let us say, do you prefer to get knowledge from the book, or to get knowledge from the media, or to get knowledge from expertise, or to get knowledge by practice? How you get knowledge?
You're giving them a clue now, Dr. Ahmed. Because the answer is all what the answer is all what Dr. Ahmed said. You learn, you read, you practice. All should go together. But what's happening in our countries? Let's get a transplant. So we get the donor and the recipient worked up by reading a book. Stick a kidney in. If it goes well, fine. If it doesn't go well, this is a problem, because we don't have the knowledge to manage complications, to manage unexpected events. So as Dr. Ahmed said, knowledge is by reading, watching, and practicing. This is called knowledge.
Yes.
Fine. So this is how to start a transplant program. Reading from the book wouldn't help you to start a transplant program. Reading from a medical book wouldn't help you to start any program, whether medical, surgical, any sort of specialties. You need the reading to be associated with practice. Fine. What else needs to establish a transplant program? Can you do it in your own? Because it's a common theme in our countries that many clinicians said, I have done 15, 20, 30, 100 million kidney transplants. Do you think the word I is ethical, is suitable for transplantation? Is the way forward to do transplantation?
So, Dr. Masoud, you can comment. Dr. Masoud. Salam.
We need patient adherent to drug and no addict and intelligent and obey doctor order.
Look, I mean, no, there's not the right answer. You need a teamwork. You need a team. Look, I'm still at the building block of a transplant program. I haven't even discussed any medicine at all. I haven't even mentioned immunosuppression or adherence or donor or recipient. None of these I mentioned. You need a team.
So, Dr. Nagwa, can you comment also?
Assalamu alaikum.
Salam alaikum.
Yes, Dr. Ho, to initiate a transcendent program, like you said before, we should know first. We can know from reading book and to enjoy a respectable program of learning. To know the basics first and to know in advance and to practice and enjoy also to join a respectable place who follow the guidelines and do the work in respectable manner to gain knowledge from the expertise and to practice the job with them and to be aware of the advance in the career by following the guidelines and to join the conferences to know what is new in the job. To practice well, like Dr. Ahmed said, we should have a teamwork. No one can do anything alone, even if he is the most intelligent one in the world. We want a teamwork from doctors, from specialties, and nurses and workers, and so on.
Excellent. Yes, yes, yes. Fine. Look, still, I haven't discussed anything about transplantation. I'm just talking about how to start a program, not necessarily to be transplantation. It could be anything else. In order to have a successful team to lead the transplantation program, what are the essential criteria of this team?
What is the question, Doctor?
What the most important criteria to establish a team, a successful team to lead the transplant or to initiate transplant program or to start a transplant program?
They must know, they have the knowledge and they have the force from themselves, the motivation
knowledge,
to be better.
Yeah, I agree. You can keep, but you can keep the knowledge for yourself. You are not passing the knowledge through. What's more important? What's the crucial?
We have a motivation to do their.
Okay, I'm motivated, but still my motivation cannot start at a transplant program.
They have the resources.
Oh, okay, we have plenty of resources, but still I can't transplant a single patient. What's important? So, the importance. Just a second, let me answer because you know.
Okay, thank you.
Yeah, communication between the team. The team won't be a team without good communication. The team is not only a transplant physician, but a transplant nurse, transplant coordinator, transplant radiologist, transplant histopathologist, and even transplant anesthetist. We should communicate very well between each other to establish a good team. What I'm talking about the basic principle to start a program, regardless whether transplantation or not. And these points, I'm afraid, is lacking in our practice in the Middle East. They don't communicate. They are well motivated. They may have the resources, but they don't communicate with each other. And communication, effective communication, is essential for the team to be successful. Fine. What about communication? Different communication between the doctors and transplant coordinator or the transplant team, or communication should be at high level with other party, like the patient. Also, we should communicate very well with the patient. In what way? Explain the risks. Listen to the patient. Answer his questions. Again, listening most of the time is lacking. Always a monologue rather than a dialogue. It has to be a dialogue. Fine. So this is just the building blocks of starting a program, even skin diseases, biochemistry, biochemical, histopathology, any program. Fine. You have a program now and team communicating with each other very well. How would you promote this program? How will you encourage people, renal failure patients, to come and see you for transplantation? How do you do that?
اتفضلي يا دكتورة أمل. Unmute yourself.
After we have the program, we should make some kind of advertising that we have the program. We should announce about ourselves and about the service we have and about the advantages about our organization and so on.
I didn't get this at all. She must be driving.
الصوت كان بعيد قوي دكتورة أمل، لو تقربي التليفون، أنت بتتكلمي التليفون. يا ريت حضرتك اسألي تاني. دكتورة أمل. اتفضلي. اتفضلي سامعيني. ويظهر التليفون بس مش مساعدة دكتور أحمد.
Okay.
في دكتورة نجوى كمان عايزة تعلق يعني دقيقة واحدة. اتفضلي يا دكتورة نجوى.
أيوة دكتور. You told how we initiate the program, صح؟
Yeah. And how we initiate it. We started a program now. How do you promote the program? How you encourage people to come and see you?
When the chronic kidney disease patient come in the clinic, when he reaches the grade 4, we are starting to learning him about transplantation and encourage him to search and to have with him that, like you told, the communication. He can ask me what is the transplantation, what is the pros and cons of this, and also to learn the family about that, to encourage them for donation. I think that.
This is excellent answer. Well done. Yes. So you start you promote the program by talking to the patient while they're still in the pre-dialysis state. So even before starting dialysis, because when he comes and see you regarding his renal failure, CKD, and he's approaching dialysis, it's quite depressing that his lifestyle will be completely changed. So this is the time to break good news for him, if he's suitable. You ask him to think about kidney transplantation. You ask him to read about it, give him leaflet, and also explain to him that kidney transplantation is better than dialysis. So you give him a hope. He will be aware that there is a transplant program starting. So you start with the patient just before landing on dialysis. Okay. Let's go to the transplantation itself. You have a donor and a recipient both coming to see you for transplantation. How would you manage this donor and how would you manage this potential recipient?
اتفضلي يا دكتورة أمل. دكتورة أمل لو معانا. اتفضلي يا دكتورة منى.
السلام عليكم.
وعليكم السلام.
بالنسبة للريسيبيانت بتكلم معاه أولا.
In English, please. In English, please.
Okay. First is the recipient. I talked to him about the percentage of successful or non-successful for the operation, and how important to the immunosuppression and keep in taking the drugs after transplantation. Tell him about everything about the advantage and this advantages of operation, and make sure that this patient will keep in the drug after the transplantation. The donor tells them about the risk for then at first and ask him for the general condition of the donor, if he has diseases or taking drugs or some else, his age, and tell him about many patient can live with one kidney, and how to keep himself with one kidney, and it may be not a disaster, and can be life for with one kidney, and tell him also about the percentage of failure of one kidney after the operation. It may be a risk of failure for him is not only due to he give one kidney and has a one. Thank you.
Fine, thank you very much. I think I trapped all of you because I mentioned donor and the potential donor and potential recipient coming to see you in the clinic, both together. You shouldn't see them both together. You should see them separately. Why?
دكتور جمال اتفضل.
Thank you, Doctor. I will answer about how the care of the patient recipient kidney transplant should be give information or give a date for a regular health care visit, and talk the patient about the medication and side effect, and also I think give information about how to eat healthy or important for keep the healthy weight. Thank you.
I think this is not an answer for my question. Maybe you haven't heard. You haven't listened to the question. The question is, you shouldn't see the donor and the recipient both together at the same setting. You should see them separately.
Separately, yes.
Yeah, and why? Why should you do this?
ايوه اتفضلي يا دكتورة أمل. دكتورة مها. طب يا جماعة اللي يرفع ايده ويتأكد بس ان هو يقدر يعمل
Doctor, thank you.
اتفضلي.
I think there is many stressful factor for the donor and the recipient. Maybe interfere in decision in transplantation. So separation between the donor and the recipient is a must from a psychological and social view.
You are nearly there, but not quite right. Yeah, nearly there. So any other smart answer?
دكتورة نجوى. دكتورة منى اتفضلي.
emotional communication between the recipient and the donor. They may be when they are both with the doctor, when the doctor tells them about the operation, they may be the emotion side makes them not concentrate with the doctor about his talking, makes them not concentrating 100% with him. So after that, ongoing in the operation, they may be in real world, and they will be maybe confusing after that, or the fact they saying the fact the operation. So when they are separating him from each other at the start, they make the doctor can concentrate with the recipient or the donor and tell him about everything about the operation, keeping the emotional side away from
You're
them.
talking about emotional
So,
side.
do you think there will be a psychological issue and maybe pressure from the recipient on the donor?
I mean, you give them the answer now, Dr. Ahmed. Yeah. So basically,
Not
I
influence the
want to
decision.
just to make sure that they will come up with this answer. Usually the pressure from the recipient on the donor, especially as a family member, close family member. So you should see the donor separately and make sure there's no pressure on him. We used to see this quite often when I was transplanting in the Middle East. You know, one patient is unwell and ended on dialysis. The family will come forward, the father and 3 or 4 sons and daughters. So all of them under the influence and the pressure of the father. Then when you separate them and you see them separately, you will realize that there is a pressure on the donor by his father. Imagine the father is the recipient, or the father or the man is the recipient and his wife is a potential donor. It could be under pressure from him. So you should see them separately. Look, I haven't discussed a single word, I haven't mentioned a single word about the transplantation itself. What I'm talking about now is the setting of transplantation, because this is more important to know. You need to have the knowledge. Knowledge means reading and practice before you start a transplant program. You need to read and get trained before you start transplant program. You're not allowed by all means to train on the job by doing a transplant. You should join a transplant team with experience in transplantation, have a track record of successful transplantation to learn how to transplant. And while reading, you need to establish a team, and a team means good communication. You may not like each other, but it's a professional teamwork with efficient communication. And a teamwork is the clinicians, pathologists, radiologists, nurses, transplant coordinators, and the patient. Communication with the patient is essential, is important. To ask him questions and let him ask questions and you listen to him. Then you come to the donor and the recipient, you see them separately. Because the donor could be under pressure from the recipient or the recipient family. Fine. Okay. So you started the transplant. How many minutes left for me, Dr. Ahmed?
ممكن نص ساعة كمان يا دكتور أحمد.
No, it's too much. Okay. So you started you started transplant program. Now we have a case on your list for transplantation, donor and recipient. What are the major contraindications for transplantation?
تفضل دكتور عماد. دكتور عماد.
Yes. Yes.
Major
Major
contraindication.
contraindication.
ايوه.
If there is any active malignancy. This number one. Number two, active infection.
Fine. Just a second. Yeah, you are right. Active malignancy. He got basal cell carcinoma.
Yes. This according to also staging of the malignancy. Is this grading of malignancy? Is this in situ or?
Yes, well done. Yes. So if he has basal cell carcinoma, do you think this is contraindication for transplantation?
I think if this only in situ, maybe can go for transplantation.
Say it again. Sorry.
This in situ malignancy.
In situ malignancy, yes.
In situ, yes.
But you need to excise it first.
Yes.
So you're talking about the waiting time now. So you excise it and you can proceed with transplantation. So don't mention malignancy without specifying the grades of malignancy. Yes. And the type of malignancy as well. So basal cell carcinoma, the zero waiting time. You can excise and transplant.
Yes.
Infection, fine. He has UTI. Still has some residual function. The other polycystic kidney disease, and he got UTI. Will you transplant him?
Yes, after treatment, we can treat, and after that, we can go.
Fine. So let me, all right, a treatment. For presented to you in the clinic for transplantation, with transplantation is happening is next week. And urine dipstick is positive. Blood, protein, and some post cells. He's asymptomatic, hasn't got any fever. Vital signs are normal. How would you make a decision to transplant him or not?
There is proteinuria and bus, and if there is leukocyte in urine, yes?
Yes.
I can go for urine culture and sensitivity.
Yeah.
To show if there is any infection, or this may be related to GN, like interstitial nephritis.
I mentioned he got other polycystic kidney disease. So basically, infection per se is not a contraindication for transplantation, but systemic infection presenting with fever, rigoring, and positive blood culture, this is definitely a contraindication for malignancy. But if you got UTI, I could transplant him. So I would change the word you mentioned, infection, I would say severe infection.
Yes.
Yeah?
Yes.
What else?
Life expectancy of recipient.
What do you mean by life expectancy? He is 90 years old. Will you transplant him?
This according to the comorbidities of recipient, not only the biological age.
Excellent. So the physiological age rather than the chronological age. So we're dealing with physiology, organ function, rather than age. It could be 90 years old, fit and healthy. It could be 30 years old, full of comorbidity.
Yes.
Okay, well done. So you mentioned life expectancy. So life expectancy is based on the comorbidities, not the age.
Yes.
Fine. So regarding the age, he's 90 years old. Do you think are you expecting transplant to prolong his life?
The problem here, immunosuppression may be more if affect him like infection like this.
No, but this is not the answer to the question. So the benefits of transplantation are three. One,
Quality of life. Quality of life.
quality of life, well done. Second, survival, they live
Yes.
longer. Third, cost, because transplantation costs less compared to dialysis. So let us say he's 90 years old. Which one he will get of the three, or he will get all three? He will live longer, will have better quality of life, the cost is less.
I think better quality of life.
Excellent, yes, you're right. And the cost as well.
Yes.
Provided that the kidney survived, how long?
Yes.
Provided that the kidney survived more than 2 years, and sometimes in American model 4 years. All right. So elderly, transplanting elderly, it won't confer improved survival because still survival is not affected by transplantation, but the quality of life is definitely better with transplantation for elderly. Fine. So what else?
If there is any recent active cardiac problem.
Fine. Recent active cardiac problem. Okay. This patient got MI subendocardial non-STEMI 6 weeks ago.
Yes.
And the change the scenario, assume that he got non-STEMI 6 months ago. Which one you transplant?
I think 6 months ago, I can go for a transplant.
Okay, so why not 6 weeks ago?
Because he is already now in, is still in, there is active problem for cardiac problem, and also he is now on antiplatelet, and should be for take for a period of time. We can't stop before surgery.
Okay, this is not the answer of the question. So what the let me put it differently. What is the chance of him getting MI, fatal MI, if he got non-STEMI or MI, recent MI 6 weeks ago?
Recent MI? Yeah, recent MI is still. Yeah,
so the mortality rate is 30% chance of getting another fatal MI if you transplanted him within the first 6 months. In addition to what you mentioned correctly, is that he will be on aspirin or antiplatelets. And usually, do you think single agent aspirin will be enough? Or he will be on aspirin and another agent, clopidogrel?
And in guidelines, they advise dual antiplatelet if the patient develop acute coronary syndrome or doing PCI.
Okay. What are the chances of this patient having MI if you transplanted him 6 months after having his MI?
I can't get your question, Dr.
Right. So basically, if you transplanted him within the first 6 months, 30% chances of having fatal MI. If you transplanted 6 months after, the chances of having fatal MI is 5%. So it's massive reduction, but still at high risk. 5% is 5-fold increase in MI in this patient. So it's not a contraindication to transplant him 6 months after his MI, but you should warn him about 5% chances of having fatal MI. So we're talking about comorbidity. What else contraindicate transplantation? You mentioned infection, and we said severe infection. You mentioned malignancy, but
decompensated heart failure.
heart failure.
Some guidelines say ejection fraction less than 30.
Okay, fine. Let's just talk about the ejection fraction less than 30. This, I'll give you a scenario. A 45 years old lady came to see you for transplantation. Her ejection fraction is pre-dialysis. Her ejection fraction ratio is 27. She's hypertensive, edematous as well. Examination showed pedal edema. There are some evidence of heart failure as well. She's orthopnic. What would you do with this ejection fraction 27?
This patient pre-dialysis, not on dialysis, yes?
Yeah, pre-dialysis, not on dialysis.
This patient first, we can decongest here, doing good.
Right.
After that, I can assess if there is low GFR, I can go for after not responding to diuretics. We can start dialysis for here.
Excellent. This is answer. Yes, 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 yes. Yeah. Basically, what I meant by this question, ejection fraction ratio could change by dialysis.
Yes.
In the pre-dialysis, sometimes they get worse.
Yes, I can repeat. I can repeat after I just dry wet for this patient.
Absolutely. So I give you some impression that this patient requires dialysis. So dialyze the patient properly for 2 to 3 months, and then repeat the echocardiogram.
Echo. Yes.
Yes. Yes. Yes. Yes. Yes. Yes. Okay. What else? Do you want somebody else to answer the rest of the questions? Because Imad is very, very proactive.
Yeah, I was waiting for you give him a difficult question so we can go forward. He's still alive. So we'll go forward with Dr. Nagwa. تفضل دكتور نجوى.
Assalamu alaikum. The other contraindication is the psychiatric patient, unless he is psychiatric patient, so he is not aware of the medications and not compliant to it, unless he has one who is caring for him. Also, if the patient
just a second, Dr. Nagwa.
Yes.
You mentioned psychiatric patient.
Yes. Severe psychiatric patient.
Severe. Okay. So dialysis is depressing. Renal failure is a disease which is very depressing.
Yes.
This means if you mention psychiatric patient, means none of them will get a transplant.
No, if he is not controlling on his medications.
Yes. This is the key word. Well done. So it's all about compliance and adherence.
Yes.
Yeah.
Yes.
Compliance and adherence.
And adherence. Unless he has someone who cares for him.
Fine. Okay. Let us just hint on compliance and adherence. Can you compare apples with oranges?
No.
No. Excellent. Can you compare dialysis with transplantation?
No.
Good. What I'm aiming at is non-compliance on dialysis. It doesn't mean non-compliance on transplantation.
Because he is depressed from dialysis. Sometimes they are rejecting the idea of dialysis.
Yeah, actually, they could do better with transplantation because transplantation is much less labor intensive for him. Dialysis will be committed to come to hospital 3 times weekly. There's a lot of restrictions.
Yes.
Not to eat this, not to drink this, watch your weight, watch your potassium, don't eat that. Come to dialysis, whether it's raining or hot weather or whatever. He will be bound to a machine Of course, we cannot test compliance on dialysis and compare it with compliance after transplantation. Transplantation will be taking medicine, becoming regularly.
But Dr.
So-
Ahmed, if he's is not complying for the dialysis sessions, but he's taking his medicine, antihypertensive, the medication, or if he's diabetic, he's taking his insulin, can you consider him compliant?
Of course, no. Look, to be honest, this is a difficult issue. We used to see this all the time, especially in young and adolescent ladies. Because they don't like the dialysis, they don't like the sight of fistula, they don't like to be, usually young ladies, young girls like to look after themselves. They like to look pretty all the time. This is natural. What we do, we transplant them because definitely their lifestyle will be completely different, but we have to train them and make sure that they will take the medicine, they take the anti-rejection. And we like to make sure as well, especially with young adolescent girls, that the medications is associated with side effects. If you give them cyclosporin, they will develop hirsutism. No girl will like this. If they get them tacrolimus, it will give them alopecia. Steroids, they swell up, swelling, and all of the striations and the cushinite faces. So you have to monitor them carefully not to develop side effects of the immunosuppressive medications, because when they develop these side effects, they will stop the medicine. So the point here, which I wanted to address, the compliance and adherence on dialysis is different from transplantation. You could help the adherence by transplanting some of these patients, but they should be ready for transplantation, fit for transplantation. So if they're attending dialysis, tell them, attend dialysis regularly, get your weight done, avoid overload, make yourself fit and healthy, ejection fraction improves, we transplant you. But you cannot transplant him while he's edematous, his potassium is high, missing few dialysis sessions, he's becoming hypertensive. This is definitely a contraindication for transplantation. Try to improve their compliance and then transplant them. Right, so this is, we're talking about contraindication, and you will address the psychiatric. The word psychiatric is not the right word. Severe is written in the book, severe psychiatric illness is nonsense. It's all about compliance. Right, what else contraindicate transplantation?
Addict patient
Addict.
until he is quit from addiction.
Fine. If he's taking cocaine or taking Tramadol, this is contraindication.
If he is dependent on it, yes.
Okay, yeah, if he's dependent, yes, this is the right word. So basically, you put him on a program to improve his addiction. But by the way, cocaine or Tramadol, oral medications can be managed easily. But the main problem is with the IV one, intravenous ones. Why? Because usually they will become hepatitis C positive, B positive, could be HIV positive as well.
Yes.
Fine. Okay. So we mentioned some viral screening here. So assume this patient is hepatitis C positive. Will you transplant him?
Yes.
But
You can.
if you give him immunosuppression, this will flare up his hepatitis C.
I think first we should treat him with hepatitis C, from hepatitis C, and after that he can go for transplantation.
Right. The success rate this day of hepatitis C treatment is more than 95%. So assume he is one of the 5% which the eradication of hepatitis C was unsuccessful. Will you transplant him?
If his liver function is okay and he is not in cirrhosis, I think we can give him the chance.
Excellent. Yes, you're right. But what about flaring up of hepatitis C after transplantation?
I don't know.
No, thank you. Actually, even if with flare up of hepatitis, definitely hepatitis will get worse after transplantation, but it will get a lot worse with dialysis. So in spite of hepatitis C, which failed eradication, when they get transplant, associated with progressive hepatitis C disease, but the progression is much worse on dialysis. So still you transplant them. Still you transplant those patients with failed eradication. Fine. You mentioned, we mentioned HIV positive patients. Will you transplant him?
Yes, when he is taking medication, I think it was.
Yes, when he's taking medications. What else? Yes, so you agree that, you know, they are transplantable. You agree that they are transplantable. It's not an absolute contraindication for transplantation to have HIV positive patient.
If he only HIV and his CD4 count is okay, and he has no malignancy, no complications, so I can give him the chance.
Excellent. Yes. You mentioned C4D count. Yes. Yeah. C4D count.
CD4.
CD4 count. Sorry.
CD4.
CD4 count. CD4 count more than 20. 200. Sorry, 200 per ml. Yes, you can transplant. And in our center, 250 per ml. You can transplant. And you mentioned there's no malignancies. What kind of malignancy is associated with
Kaposi sarcoma?
Kaposi sarcoma. Right. Okay. Yeah. Excellent. And what else required for HIV patient to be eligible for transplantation?
He's compliant on his HIV medication.
Yeah. Thank you. Yeah. Excellent. I think, you know, well done, Nagwa. What else contraindicate transplantation?
Severe obesity.
Severe obesity. Excellent. What do you mean severe obesity?
As the patient body mass index more than 40.
More than 40. Why?
Because in these patients, they are first it is a difficult operation. Second, they are prone to for focal segmental glomerulosclerosis, so it can occur in the graft, and also the wound healing is very bad for them.
Yes, I think you addressed the point. Technically, it's difficult. So associated with much more surgical risks as well. In addition to obesity, is associated with chest problems, DVTs, cardiac events as well, and they become diabetic if they are not diabetic before the transplant. So what would you advise them?
For weight loss first, if we can go for him for bariatric surgery first, and after that they can go for transplantation if they reaches a desired weight.
Well, imagine this is a donor who's obese.
Also, it will be difficult surgery for him.
So,
and wound healing will be not so good because the wound is very big in the donor. But it is not absolute contraindication.
Look, to be honest, the obesity has significant impact on kidney donation more than the transplant itself. Because you will leave this patient with single kidney. And he will have secondary FSGS and all sorts of things, all sorts of complications, hyperfiltration injury, in addition to the chance of becoming diabetic and hypertensive if he's not hypertensive. I mentioned hypertensive here. It's hypertension contraindication for donation. I'm moving now to donation.
If the patient is controlled the hypertension with one single medication, he can go for transplantation as a donor.
Yeah, Negbo.
And first, we should
It looks
follow
like
our
it looks like
important.
looks like you work in a transplant unit. Do you?
No.
Preparing
But,
MD,
no.
PhD, because your answer is perfect. Yes, controlled blood pressure on one or even two medications is not contraindicated, provided that. Complete the sentence.
The patient is known the patient knows that the risk if his blood pressure is controlled about the donation. So
Fine. Let me just give you a hint. So you have done an echo. His blood pressure is well controlled on one medication, and you have done an echo, and the echo showed mild left ventricular hypertrophy.
so there is target organ. So I think it is not good for him for donation.
It's contraindication for donation. End organ damage. This is what we call it. Yeah. If he has end organ damage secondary to the hypertension, this is contraindication. If he had a stroke, this is contraindication even on single medication, even well-controlled blood pressure. If you got evidence of proteinuria, this is contraindication for donation. Okay, fine. So a donor, you did work up a donor. He's not obese. His BMI. We talk about obesity. Usually, we talk about BMI. His BMI is 30, and you did his blood pressure check twice, which was normal. Urine dipstick showed traces of blood. This is a female patient. What would you do then?
His hypertension?
No, no, it's not hypertensive. She is not hypertensive.
Obese? She is obese and has
non-obese. Non-obese.
Yes. So only problem is microscopic hematuria.
Microscopic, yeah, traces of blood. Yes, microscopic.
We should repeat the sample after 2 weeks.
Yeah, I mean the hint here. She's a lady. It could be
menstruating.
It could be menstruating. So you repeat the sample. Fine. She's below the age of 40, and you repeat the sample. You repeated the sample and came back still positive.
We should investigate her for hematuria if she has.
How would you? Yes. How would you investigate her for hematuria?
Ultrasound first, and so to see if there is any gravels, and she can do for CT-QB also.
CT-QB is normal. What are you looking for by requesting CT-QB? Stone. Okay, there is no stones.
And still hematuria, no proteinuria.
He hasn't got proteinuria, just hematuria, microscopic hematuria.
And no stones. And she is living with that 40, so the chance of malignancy is not our differential diagnosis.
What you need is here, in this case, you do cystoscopy as well.
Investigate.
Fine. Cystoscopy is negative. What else you need to do? Still got microscopic hematuria. Now you collected 3 samples. The 3 samples showed blood. Microscopic.
Renal biopsy for here.
Renal biopsy. Yes. Yeah. Okay. Yeah. Yeah. You do biopsy. Surprisingly, we've been transplanting for a while, and we have done only one renal biopsy on a donor. None of, all the cystoscopies except one showed some trabeculation of the bladder, but all cystoscopies was negative. And even the renal biopsy we did was absolutely inconclusive. So the biopsy is inconclusive, cystoscopy was negative, and it still got non-visible hematuria. Will you take his kidney or her kidney?
No, no.
She's 38 years old.
Yes. I
Why?
will not take her.
Hmm?
I will not take her kidney.
Why?
Maybe she has focal segmental glomerulosclerosis, and we take.
Just a second. Why focal segmental glomerulosclerosis? She hasn't got proteinuria. What else is relevant here?
Alport syndrome.
It could be Alport, yes. Okay, but Alport actually, in ladies, you can detect Alport by, electron microscopy. What else in the Alport group? It could be thin basement membrane.
Yes. Yes.
It could be IgA nephropathy.
Yes.
Yeah, there's a whole loss of differential diagnosis. Okay, fine. You transplanted. Okay, let's just move to the transplantation. You transplanted this guy successfully. Which fluid you would give? Normal saline or Ringer lactate or lactated Ringer in the post-operative period, and why? Somebody else to answer this question?
لا ما فيش حد تاني يقترح للاسف.
Okay, fine. So basically, normal saline, just to let you know, normal saline is abnormal saline. Normal saline is not normal. So we normally give lactated Ringer because it's more physiological. Of course, I will later on, I will give you a talk when time comes on fluid management post-transplantation. You will discover that there is an inherited myth. Normal saline is normal, but normal saline is associated with metabolic acidosis, subsequently hyperkalemia. So it's recommended for living transplantation to give lactated Ringer. Anyway, thank you very much. I finished just brainstorming, and what we conclude today is, in order to start transplantation, you need to build up the knowledge, you need to build up the experience, you need to communicate, you need to establish a team, and then when you start transplantation, you have to have open discussion with the donor and the recipient separately because of the pressure on the recipient family, on the donor. And then we talked about some indication and contraindication for transplantation and kidney donation.
Thank you very much, Dr. Ahmed, for your great discussion, and everyone participated in this discussion. And I hope you can stay with us until we have a summary of discussion at the end of the session. And now we will go forward to present Professor Faisal Shaheen. He will talk also about setting up transplant programs. So please, Professor Faisal Shaheen, you are welcome to start your talk, inshallah.
Thank you very much, Ahmed. This is a great chance to be with you in this very important teaching program, which I enjoyed very much. And it's very difficult to speak after Prof. Halawa because he had a special character giving his talk. Myself, I have a questions for him, but I'll keep it till the end of my talk. He spoke about the transplantation from the patient side, and I'm going to speak about how to make a transplantation and what's the outcome of transplantation. And just to think about transplant either from deceased donor or from living donor, you have to think about legislation, which is important. You have to be justice, fairness in distribution of organ, fairness to give it to the patient. And so the essential for modern human society is the fairness, justice, freedom of choice, and this is the future development of organ donations, either it is kidney, liver, heart, or living or deceased donor. This is in 2010, the World Health Assembly resolution 63.22 about human organ and tissue transplantation. This is mainly targeted all the government, international authorities, in order to have their own oversight program to look for the transplantation and to have one organization to look for organ donation and transplantation in order not to bridge the people to go for commercial transplantation. And for the future, for any government, they should think about to be self-efficient from organ transplantation in their country. Now I'm tackling the problem one by one. We go for a living donor. From where we get the living donor, usually it is the donation from living is from relative. There is some, and those relatives are either genetically related or emotionally related, but still we have a problem with the commercial transplantation in some countries. For the deceased transplantation, which is a great potential, and we have to think, now you are speaking about in Africa and in Asia, Middle East, Arab world. We have to think to create a disease transplantation program. It is very important for us. Still, even if there is a little harm to the donor, living donor, we have to think about this a little harm. We have to go for disease donation, which we are not going to harm anyone. So, and we have again the potential. We have accident, which is never end. So we have so many brain disease cases, and we can utilize those brain disease cases and finish all our waiting list for kidney, liver, and heart, small bowel, and others need, even pancreas. But still, we are facing a problem that the brain death concept is still debatable in some countries, especially in our area. And I think myself and many others think that having a donor, a deceased donor, is more ethical than to go for commercial transplantation. Overall cost, we are in, let us say, a poor countries in Africa and in Asia, relatively the income is low, and we have to think about the cost. Still, the dialysis taking the high, very high up, as you can see, this is high, more than go for transplantation with full match.
ما فيش قدامنا سلايدز يا دكتور فيصل.
Oh my God, you have to share it.
عايز تشير السلايدز اتفضل.
Yes, okay, please. So I have to go out again, escape. Where is your sharing, Ahmed?
من الزرار الأخضر اللي في النص.
I know, but again, we have to come down again. Sorry for that. Sorry that we missed all of this, huh?
انا قلت لحضرتك يعني اوبن ديسكشن وكده، فقلنا مش مشكله.
اوكي.
هو في شيء باين بس مش كامل.
Is it okay?
مظبوط كده، لا شكله مش مظبوط يعني. كده ممتاز قوي، بدأ خلاص كده. كده واضح جدا. number of people requiring dialysis per transplantation.
Okay. So again, sorry for that, Ahmed. Okay, as I will return back to one important point, since we are in a countries where the income is less than the rich countries, you can see that the dialysis costs more than transplantation. Either if you take 0 mismatch or 46 mismatch, ABO incompatible, and all of this is still lower than the dialysis cost, which it is very important. And even the survival, as you know, that with the transplantation is much, much more better than the dialysis patient. Worldwide, we are transplanting around 130,000 solid organ transplant per year. 17.6% of them is from deceased donor, and still this number is very small if we compare it to what we need. So every 10 patients, we transplant only 1 patient. So 10% of the global need, and the transplant waiting list is going more and more. And 10% also of the transplantation is done by the commercial transplant, which I'm going to explore later. This is the waiting list, not only in our countries, it is everywhere in Asia. The waiting list is getting more and more high. North America, Latin America, European, Africa, and many, even Arab country, all the waiting list is getting more and more because there is no available organ for transplantation. What about the activities of transplantation? The most greenish here in the map is the high activity of transplantation. As you can see, it is in Europe and in North America is the highest number of transplantation. But in Africa, let us see, we have only few countries which they are doing transplant, and some we don't have data at all, and the others very less transplantation. In Africa, we have South Africa, and in Egypt have living related not deceased. In Sudan, we have in North Africa, in Algeria, we have a good program, Tunisia, and also in Morocco, but still this is a limited number of patients which go, especially deceased donation. I will give you the model in the world, how the world is going with the transplantation activity. The highest number of transplant in Spain, and they have around 49 per million population donations. And then after that, United States, and you can go to France, which is again a good number. Australia is 20.8 per million population. But if you look for this map, you will find that there is a variation in number of transplantation. The number is significantly changeable from one country to another, even in the same area. Like in Europe, we will find difference between Spain and Germany. Germany 10.4, in Spain 43.4. So there is a difference in this. But look in some small countries like Croatia. Croatia, their program was very primitive program, just till 2009, where they start to have initiative and take what's going on in Spain, implemented exactly in Croatia, and you can see the number of the transplantation activity. Now they are reaching up to the Spain, so they are almost in the same head-to-head to the Spain. And this is coming from deceased donation, which again, if we have a good program, probably we can do better, we can transplant all our patients. Some other country, like in Japan, we know that Japan is a very advanced country, but in transplantation, they are poor. Why? Because before 2009, they don't have law for transplantation. And they start to have law in 2009 to agree about the transplantation from deceased donor and even living donor. They are, for everyone to know that in Japan, they have the lowest mortality rate in dialysis patient, and the survival of dialysis patient is very high in compared to any other countries. At the same time, the waiting list is very big because they are staying long in dialysis and they don't have transplantation. In 2009, they agree about the law about the transplantation activity and transplant from deceased donor, and they start to have few deceased donors. But the law itself was very rigid, so they don't implement it easily. And that's why things getting worse after that, and there is no more deceased donation, except after one minister come change the law, and they started to have more deceased donation after that. But what's affecting organ donation? I'm speaking here about deceased donation, which is important, which I'm looking forward in Africa to start to have a good program, deceased program in those countries in order to save the patient. There are many factors which can affect the organ donation, either religious factor, consent legislation, economy, organ procurement, organization, culture, commercial transplant, and some other hidden factors. I will tackle this very quickly because of the time. Just to give you an idea, is the religious play a major part in organ donation? No, it is not. As you can see, the highest number of transplantation here in Europe and in the United States. And the majority of the people on those two countries and those two places in the world, they are Christian. But still, you have in South America, many Christian, in Africa, many Christian, and those don't have a good transplantation activity. So still, it can hinder some of the transplant activity, but not to that much. So we shouldn't always say that religious is hinder the transplantation. By the way, all the religious accept transplantation, or the religious actually pushing for transplantation and consider it as a humanitarian and to help the poor patient. The second point is organization. As we know that we have the legislation, two kinds of legislations, either opting in system or opting out system. What's this mean? Opting in means that I have to take a consent from the next of kin about the transplantation. Or I have opting out, which it is not necessary to take opinion or agreement of the family about donation. And the opting out system, as you can see, this is the blue card here. This is opting out system, especially in Scandinavia, in Russia, Uzbekistan, Kazakhstan, and some of the Europe countries, 6 Europe countries have opting out system. But all of this doesn't have too high transplantation activity, which again reflects that either you have opting in or opting out system, still it doesn't play a role in transplantation. What about the economy? There is no doubt that money, if you have money, you can do anything. In transplantation, still the rich countries do well because they have organization to do that, but not because they are rich, they have more transplant activity. Iran is one of the countries which have a very good transplant activities, and yet the income is very poor, but they have a good organization to look after transplantation. And here again, if we look for the South America, North America, both are good economy, but still the transplantation difference between the two countries. What about organ procurement center or OBO organization? What we can see here in the map that there is no country, the countries without OBO doesn't have any transplant activity, but all the countries which have OBO, they have transplant activity. So this is one of the important factors which we should have it in our countries in order to initiate organ transplantation. What about the culture? Everyone knows that the culture is a combined factor like family, education, economy, religious, politics, healthcare. There is interrelation between the society and transplantation across the world, which can affect the culture. And the culture is different from one country to another. And also within the country, there is different culture as well. So it plays a role about the belief in some of the peoples in some countries about the brain death, about the donation, about the transplant. We have some believers that they don't think that transplantation should be performed because it is forbidden. Till now, we have it in our area here. So the culture is a product of the society, institutions, and family, education, economy, religious, politics, and healthcare. And as I mentioned, culture is different from one part of the world to another. And there is several cultures in the same homeland. And there is no better culture than the other. Everyone have his own, and there is no conflict. If we have conflict, we have a problem within the country as well because of the changing of the culture or different culture. Now I'm coming to the important point which we should know that about. In my own view, I make this slide long time back, which is speak about ethical direction of transplantation and unethical direction of transplantation. The ethical one is that you go and transplant in area where you have a good facility of transplantation, where you have a good success of transplantation, where you have a transplant center which are taking care of you pre and post, and the outcome of that center is excellent, and at the same time, it is not experimental thing. And this is, you can see some people going for ethical direct. So they are not going to buy a kidney or to buy a liver. They are taking their donor or the donor in other area, taking them, go to the good facility. But the other one, which are unethical, is that someone who is rich or he can pay money, go to the other country, and take an organ from there, from a poor people, and this is considered to be unethical. It is not only in our area, it's even in Europe, even from United States, they are going to different places in order to get organ. The patient in need and go and he can buy and sell kidney in different places. Till we got this important picture, maybe everyone see it, in the magazine about those donors, which is a very poor people. It was a very small amount of money. They give it to them and they take their kidney, and the organ was for sale in some of the Asian country. And after that, we have a different meeting in order to establish what's known as Istanbul Declaration Against Commercial Transplantation. And this is, the media didn't stop actually. So they were following those transplant tourism everywhere, in Egypt, in Saudi, in Israel, in United States, and everywhere, in China. So there are many group of people going after those people, and they target the transplant commercialism, and they announce it in the media, and the action taking after that in Istanbul Declaration. And here you can see the Tribune, which were speaking about how big is that transplantation tourism, which they said that this is the illegal global organ trade generate profit between 600 million and 1.2 billion per year, which is a big amount of money. And 10% of our transplant patient activities, unfortunately, coming from the commercial transplantation. And this map, you can see the recipient country and the seller country, which is, again, no one expects this. Everywhere you will find one of those countries advanced in transplantation, yet they're still involved in commercial transplant. I initiate with our colleague, Dr. Assaig, with Frank Delomenico, what's known as many meetings in order to come over this commercial transplantation. We have a meeting in Dubai, then at the end, we end up by what's known as the Istanbul Declaration. And this was a very big meeting. And after that, we were against commercial transplantation through the WHO, and it being implemented by WHO and even Transplantation Society. So at least out of this, we started to have less commercial transplantations, significantly reduced in China, which they don't have any activity now, very rare to have commercial transplant. In Filipino, they were allowed to give as it's not prohibited to have a commercial transplant, but after Istanbul declarations, only 5% of the donor became a foreigner. In Pakistan, they closed all the facilities of transplant tourism. In Egypt, they have a law of living donation. In Colombia, they have also new law. And in India, it become very less, not like before. You know, it was in Pakistan and India, it's like a bazaar. If anyone wanted to have a kidney, he just go and get it within a week and return back. For your information, still, if you wanted to initiate, to make a transplantation program, you have to choose the legislator, because there are some hidden factors which affect transplantation. One of this is the legislators. If you have the one who makes the law is not understand about the problem of donation and transplantation, this is a problem, because they will make a difficult law in order to get a transplant. And that's why you have to consult expert in transplantation. The medical community in large, there are still till now some medical professionals not or partially supporting deceased donation in practice, even living donation. And some ICU physician having doubt about the brain death and declaration of the brain death. This, you have to overcome this by teaching, sitting with them, show to them, and give them the evidence, and probably they will turn out to be with you. What about the public? Public is important. The public should be aware about the importance of this transplantation. They should be aware about the brain death, and they should be aware about the outcome of the transplantation and how long the patient will live, about the economy. So we have to even to be very transparent with the public in large, and to have a positive attitude toward organ donation. As I mentioned, in Spain, they have the highest number of deceased donation. And they didn't think that legislation is important. They didn't think that the campaign, promotional campaign is important. They didn't think that donor registry is important, donor card is important, driving license, other methods of promotion. This is their way, but every country has their own culture and their way, and I think this is one of the tools which we should publicize the organ donation. In Spain, as I mentioned, one of the highest country, and they started by 20 coordinators in 1988. Now there is more than 200 coordinators, and in each hostel they have transplant coordinator. And this is to show that the 5-year cost of the dialysis around 200,000 euro per patient, and for transplantation only 60,000 euro per patient. Again, as I mentioned in the earlier, that transplantation is much more cheaper than to go for dialysis. I mentioned about Croatia, and Croatia is a good example, and they started to implement the same what Spain is doing. As I mentioned, there is an interrelation between the society and transplantation across the world. And what we have here, the ethics, it's been approved by all the Middle East country, Arab, African country. Religious, as I mentioned, all the religious push for transplantation, legislations approved. Cultures, question mark about it, because there is some in the culture doesn't accept transplantation. Like even in some, very civilized country, they don't accept sometimes blood transfusion, and they don't allow that. So still, we have some people doesn't accept the concept of brain death. So all of this, we should have it in order to have a good program And the three below important is to have a government support to regulate the transplantation. We have to have religious and social support. The culture is very important to look for those people, the in-large and of the public in large, and to convince them about transplantation. And as I mentioned, OBO is important. You have to have a center to oversight the transplantation activities. I have one question from one of the colleague, maybe the question given to someone, one of my colleague who gave a lecture about how to have a new transplant center. There is some infrastructures to have a transplant center. And the basic things is that I will go quickly in the working staff. You have to have at least consultant nephrologist with a minimum of 1 year experience with a recognized kidney transplant center, at least one nephrologist, transplant surgeon with minimum of 1 year experience in recognized kidney transplant center. Nursing staff, they must be highly experienced to care of the patient during and after kidney transplant. Organ transplant coordinator, which have adequate experience in order to perform duties. Dietitian, social worker. From the technical point, you have to have in the hospital dialysis facilities, hemodialysis, CABD, IBD, others. 1 or 2 of them is enough. You have to have isolation of dialysis machine in some patient who had get infections or hepatitis B or C. And also you have to have portable machine. From the nephrology side, you should have the facility, inpatient bed to do dialysis, OBD, kidney biopsy, transplant clinic, equipment which you need, intensive care unit. You have to have cardiology facilities, gastroenterology, chest physician, radiology, hematology, including blood bank, pathology laboratory, biochemical laboratory, and at least 2 operating rooms must be available. At least 2 rooms, post-transplant care should be available. The working, you should have all the laboratory work like CBC, ESR, urine, AFB, hepatitis screen, ACG, chest X-ray, tuberculin test, CMV, HIV, malaria, bilharziasis, sickle cell screen, abdominal ultrasound, maculating cystourethrogram, blood group and cross-match, HLA typing, cytotoxic antibodies, echo, cardiac stress test, coronary angio, Doppler vascular study, blood level of cyclosporine, tacrolimus, and CT scan. And you should have drug available like tacrolimus, cyclosporine, MMAF, azathioprine, prednisolone, and anti-rejection therapy, methylprednisolone. There is no more OKT3, so it's not necessary to be there, but you should have ATG, ALG. One of them is quite enough. You have to have the solutions, urocolons or equivalent solutions for perfusion of the kidney. You have to have drug which treat viral infection like acyclovir and some other which is for parasitic infection. Again, I will return back about the importance of some aspect, which is the religious and social acceptance of the transplantation, even if it is living related, because as it's mentioned by Prof. Halawa, that transplantation, it is, you can say it's simple, but it is very difficult. The outcome is important. So you have to have acceptance from the community that you get a transplantation, and you have to have someone who can oversight the transplantation activity. Government support is important, or whatever, you have some institution with support transplantation. And we notice that if you don't have government support, if you don't have someone behind you, stand behind you, pushing you for transplant, you will afraid, the physician will afraid to do any action, because as you see, this is, the patients can die next day because it is very rare, but it could happen. And this can create a lot of problem for physician and transplant nephrologists. National Recruitment Center is important, and we have few of them like Saudi Center for Organ Transplant, Tunisian, Jordanian, you have in Lebanon, some, any country which have transplant, usually they have, they have a center which oversight the transplantation activity. Just an example in our area here in Saudi Arabia, how to initiate or to make a transplantation program, the authority should give into the OBO, like Scott. Documentation of the brain death should be strictly by some protocol. Not everyone come and document the brain death. No, you have to have a national program for that. So, and no variation, because this is a fixed, and this is how to go ahead with transparency with the community, and to be sure that the transplantation member should be not involved in a brain death documentation, and the consent should be written from the next of kin at least. This is in how things in Saudi Arabia. We have the intensive care linked to the SCOT, and we have 25 centers, and this is 150 donating a hostel. We have regional offices, 4 regional offices, and all report to the SCOT, and the SCOT taking care of the brain death cases and activities. Before, everyone was from back door, but nowadays we said that ICU should be involved with our SCOT administrative in order to increase the number of donation. And so again, I'm coming back to conclude in some of the few slides. We have to deal with the press and media in order to promote organ donation. We have to deal with the leader of the religious and attitude in public as well. This is one of the seminar and which we did in combination with the international societies in order to promote organ donation. This is the team from Spain. Many times they came to Saudi Arabia, and we make such congress in order to promote organ donation. Also, this is another team from International Society of Organ Recruitment and Transplantation in Riyadh, advanced course of organ donation. This is important things to be done in order to promote organ donation. We never forget the media, which is important, and the authorities, people which can help us also to move forward for organ donation. We have the campaign of organ donor. Nowadays, it's more better. We have it in by smart telephones. You can be an organ donor immediately without going to somewhere and to write it or something. You can do it yourself. So this is again one of the campaign, and I will skip some. Some of you will ask about xenotransplantation, where we are. As you can see that FDA just recently approved to use animals studies in order for organ transplantation because of the shortage of organs. And but still we need years for this to be implemented. For organ regrowth, we have many organs regrowth, like trachea, like some of the urinary bladder, but still denervated, and we need time to have something out of it. The ideal model for organ donation is to have national organization, OBO. You have to have approved legislation. You have to have funds for that. You have to be supported by the religious authority. You have to have direct approach with the training to the medical community. I summarize by this slide, which I make the priority, which we should have it in organ, in order to have good organ program. The national OBO is the first one, which is the highest one. Medical community in large is also the second, and we have to deal with the culture, but not to that limit. And then the legislation, economy, religious, again, it's play less part on this. So the three important is to work in the medical community in large, organ organization, OBO, which is important, and to deal with intensive care people inside the intensive care. We have to think about self-sufficiency for organ donation. We have to stop any patient going for commercial transplantation abroad, and it is by law, it is everywhere now, it is prohibited. And we can, for sure, that have a good transplantation program with a simple, infrastructure, which I mentioned. It is all in, you can find it in a good hospital, but you can just reorganize it in one place and do your transplantation activity. Thank you very much. I'm ready to answer any question. Your sound.
Thank you very much, Professor Faisal. It was an elegant presentation. You covered all aspects of transplantation and how to set up a successful program. And also, it is very nice to show that religious is not the main pitfall or main obstacle in front of the transplantation, but mainly culture and maintaining the legislation and the national support is one of the most important ones. I ask if anyone having a question, please raise your hand to Dr. Faisal. So we have Dr. Nagwa, please unmute yourself.
Assalamu alaikum. Thank you, Dr. Thank you, Dr. Faisal, for your excellent presentation. I am asking about in Saudi Arabia, how can we join the patient in Ministry of Health to the transplantation program? The newly patient come for dialysis and he want for transplantation. How can we join him for the transplantation program in Saudi Arabia? And also I want to ask if there is a high percentage of acceptance from the next of kin of the brain patient for donation. Thank you.
المايك برضه دكتور فايز. المايك.
Thank you, Dr. Najwa, for this elegant two questions. The first one about how to refer the patient for transplantation. First, if the patients have living donation, there is no problem about this. Living donations, he can have transplantation anywhere in the kingdom. He can choose even between the center, which center is better than the other, especially if he's Saudi with the donor. If the patient doesn't have donor, and I think this is what you asked, how to refer the patient which need a transplant to be in the waiting list. Every dialysis unit, they have what's known as waiting list area, and they send it to the SCOT by number and data registry. They can be in the waiting list. There are two waiting lists. One is the transplant. Each hospital in the kingdom belongs to one transplant center. And that hospital which he dialyzed, it's belonging to one center, which he can send his paper to that center or to the Saudi Center for Organ Transplantation, where they can send to the center and they can put him in the list, in the national waiting list. So we have local waiting list and the national waiting list for each patient, but the initiative coming from the dialysis center where he is. I forget the second question.
Is if there is a good acceptance from the next of kin of
yes. About this is we go with Sharia. Actually, this is before initiation of the transplantation activity in the kingdom in 1979. And in 1986, they have agreement from Sharia about transplantation from living and deceased donor. And one of the criteria that you can have next of kin to give this like heredity. If someone died, who's going to take his inheritance is the next of kin. So usually you take if the father take the son, and the family consent. If the son take the father, so it is exactly by Sharia law.
Thank you, Doctor.
Thank
So
you.
next we have Dr. Gamal from Libya. تفضل دكتور جمال.
Thank you, Dr. Faisal, for this nice presentation. Just I have a previous information about Japan. I don't know now if it's true or not, because the Japan have a religious belief about the prohibition of the organ transplantation. That's why the Japan is very development in the manufacture of the dialysis material to simulate the natural kidney, because that's why the dialysis patient has a high surveillance rate for.
Okay, shukran, Dr. Jamal. Sorry for, I think that your information is not complete about Japan. Japan in 2009, actually late 2008, they agree about the brain disc. It's a brain disc. I know that from their religious, they don't think about the brain disc, but in 2008, they have it, and they have it in parliament to agree about the brain disc and permissions to take organ donation from the brain disc. And they started to have organ donation. And now they have actually many cases from deceased donor. But the law in Japan said that if someone wants to donate, he should go during life to the court and make a consent for donation during his life, which is, again, it is not logistic. If someone, no one know when he will die, no one know. So this was, the law was tight. And in 1996, there is one minister, in 2006, there is 2016, one minister come and he recognized that there is a problem with the law, and he changed the law. He said there is not necessary to have the donor being consented in this, and next of kin can give the permission. And that's why they started to have disease program after that. We know that there are so many waiting lists, that we know that the mortality is less, but still they have a good program at the moment. Thank you, Kamal.
Thank you.
So any more questions?
I have questions for Halawa.
Yeah.
Halawa, I enjoy
Halawa, he went to airport. Sorry. He had to leave to airport.
Okay.
So we will have a question now from, we will close this mic first, and we will have a question from Dr. Ben. Dr. Ben, originally from south of Sudan, and he is working in Kenya. تفضل Dr. Ben.
Yeah, thank you, Prof. Ahmed, for this chance. Actually, it's not a question, but it's a more of appreciation to Professor Faisal. We actually learned a lot from this presentation. It was very fantastic and very excellent. Thanks.
Thanks, Ben. Thank you.
So at the end, Professor Faisal, if you have questions to Dr. Halawa, give it to me. I will give them to him.
Yes, I will give it to you, Ahmed. Actually, if we have a donor or recipient gave history of cannabis abuse or whatever uses, you accept them or not? Which it is a common problem which we have it in our area.
For the donor, I need to refer him to a psychiatry as we all do, to check his ability to donate, and he is not under pressure. For the recipient, I need to make sure that he will take his medication, because you know cannabis can make hallucination. So he can imagine that he's taking his medication, and actually he is not. And he will be in good mood whatever happened to the graft, because he's on cannabis. But I need to know your opinion as well, Professor Faisal.
So you promote cannabis, you promote it, because if someone become happy, he will be happy.
No, I don't promote it, but when I was in UK in between 2002 and 2004, it was not prohibited, and even it was one of the celebrations of the National Kidney Fund during our nephrology meeting. So after the meeting, you can they can serve you cannabis in UK in 2004.
Okay. Okay, I think again, maybe some people who is rigid, they will not accept donor. He had few times cannabis before, but again, myself, if the patient not so heavy smoker, not everyday smoker or something, probably he can be accepted, especially if he is willing, as you mentioned, and he will be referred to psychiatrist. Psychiatrist will evaluate him and see if he clear him from psychiatrist. I will accept him as a donor. For the recipient, we have to advise him that to stick to his drug, and we can see his report before how he behaved during dialysis. Did he miss the dialysis? Did he taking his medication or not? If he's missing the dialysis, not taking medication properly, to avoid him till he stop taking cannabis. And we have to check that in his urine, either he is still taking or not.
Yeah, exactly. So I will have a comment from Dr. Ben. Maybe he has also an experience with cannabis or cannabis patient.
Not actually, not actually experience with cannabis, but I want to ask Professor Faisal, because recently I had a case of a donor who is actually a young man, a heavy smoker. So what we did is we just referred him to mental health for counseling and the possibility of having clearance from them. Then we can proceed. So is it the same thing that you are doing, or there is something different?
No, it is the same. You send him for counseling, and he will say that I will stop smoking, but he will never do that. And you have to accept whatever he said, and if his health as a whole is good, it's good. Otherwise, you will defer a lot of patients who smoke, or a lot of donors who smoke, and there is no proof there is a direct effect of smoking in the kidney. Maybe Ahmed can correct me in that. And it can affect the health as a whole, but not the kidney itself.
Professor Faisal, there is some reports that they can affect the kidney tubules through many products from burning of the paper more than the tabg itself.
Okay.
But also, you know, he will go for major surgery, and mostly such heavy smoker will have problems, many issues in his lung, and sometimes anesthesia cannot accept him for the operation. So we'll have question from Dr. Ghada.
Agree.
Dr. Ghada, unmute yourself. Dr. Ghada. يا تفضلي unmute yourself. إذا في مشكلة في الميكروفون بتاع الدكتورة غدا مش شغال يعني. طيب دكتور بين again.
Yeah, I just want to ask for this issue of smoking. is there any timeline we should wait before accepting the donor? Timeline. Thank you.
Timeline for accepting the donor with heavy smoker?
Yes, I mean, if you had a donor already who's heavy smoker, for how long you should wait until you accept him as a donor for possible donation? Is there any timeline here? For example, if you went to the mental health and then cleared in 1 month with a letter that he's okay now, should we proceed or there is a specific timeline?
Well, I think, Ahmed, if you allow me, I think if someone is smoke, you cannot, go after him and see either he is smoking or not, especially if it doesn't affect his lung or something. So he should be examined. He should be advised not to smoke, and probably tell him we'll give you 3 months. If you stop smoking, come back for donation. If not, don't come. This is like the obesity also. One of the tests that he is willing to donate or not. And if he is willing to donate, he will come to you and say that, okay, I stopped smoking. Even if he didn't stop, this means that he is willing to donate. So this is just a test which the late Dr. Al-Khader actually was putting it for some donors like smoking, obesity, hypercholesterolemia or something. Just tell them, go try to collect yourself and come in 3 months, and then we re-examine you again. But anyhow, you cannot send someone behind him to see that he smoke or not. He can smoke without telling you.
Yeah, exactly. دكتور مسعود اتفضل.
عليكم.
Salam.
Thank you so much, Professor Faisal, for your elegant lecture. Can I ask you one question, please? Is there bird donation in KSA? And if not, can we see it in the future as between our countries or at KSA?
I didn't. You mean share donation?
Bird donation.
Bear donation. Yes, we have it. We have 3 centers doing a good program for bear donation at King Faisal, both in Riyadh and in Jeddah and Dammam also. We have 3 good centers. They are doing bear donations. Yes, we have it.
Thanks. That's my professor.
Any other questions? So we reached the end to our session. I would like to thank Professor Halawa. He had to rush to the airport. He has a meeting elsewhere. And I would like to thank our Professor Faisal Shaheen, for this detailed presentation about that updated our information about transplantation and the very nice, elegant discussions. I think I am lucky to have Professor Faisal and Professor Halawa in one session with this heavy discussions and interesting questions also from the audience. Thank you very much, Professor Faisal. And tomorrow at noon, at 2 p.m. Cairo time, we will have a small celebration to acknowledge our speakers and to give certificates for our attendee. And for our attendee, we will have exam in 5 minutes that will be open, and I will send the link after we finish our session. So thank you very much, Professor Faisal. Really, it is our honor to have you not only for today, but all the 10 days you were with us, supporting us hand in hand. And I am seeing you active every day. It is very exhausting, and I would like to extend my gratitude and thanks again. Thank you very much, and have a good night.
Thank you, Ahmed.